Now, the topic for today's roundtable is Venetoclax, everything you need to know. This topic is one I am really excited to bring to you today. In our Facebook groups and in conversations I have individually with community members, I've been hearing a lot of questions about medications and about Venetoclax specifically. AML can be a real whirlwind of a diagnosis and the treatment experience. And a lot of times it's everything you can do to just keep your head above water as you start to navigate this disease. So we've designed today's event to give you a resource you can look to get answers about a therapy that a lot of patients have been on or will be on. Today, we're going to talk about what this medication is, how it works to treat AML, and then how this medication is dosed. Then we'll open it up for questions at the end. Let me take a moment to introduce our two panelists today. First is Dr. Catherine Lai. Dr. Lai is an associate professor and physician leader of the Leukemia Clinical Research Unit at the University of Pennsylvania. She's board certified in hematology, oncology, and internal medicine, and she specializes in detecting, monitoring, and treating acute leukemias and myeloid malignancies in adults. Dr. Lai's research focuses on novel therapeutics, designing and conducting clinical trials and health outcomes for leukemia and myeloid malignancy patients. And then our second presenter today is Dr. Mannis. He is an assistant professor of medicine in the Division of Hematology at Stanford University School of Medicine and medical director of Stanford's Inpatient Leukemia Service. He specializes in the treatment of AML, high-risk MDS, and other hematologic malignancies. As a clinical scientist, Dr. Mannis divides his time between caring for patients, teaching trainees, and researching novel therapies for AML and for MDS. I am so excited to have these two incredible physicians here with us today to help us address this topic. So with that, I'm going to go ahead and turn the time over to Dr. Lai.
Great. Thank you so much. Good morning, everybody. I am going to share my screen. Okay. There we go. My screen up and ready?
Yes.
Okay. Okay, so I'll take over the first part, and then Dr. Mannis will take over this part two. So I'll just really get into the background of what is Venetoclax and how does it treat AML. And actually, but even before we do that, I just want to take a step back to put us all on the same page, because I know that we have different amounts of information on AML. And so just broadly, when we talk about leukemia, we break it down into 4 different types. There's acute and chronic leukemias. So AML, as we know, is an acute leukemia. And then based on the cell of origin, or where the disease begins, is either something called a myeloid origin or a lymphoid origin. So as you can see, this is now broken up into a nice 2x2 table, where you have acute leukemias being AML, acute myeloid leukemia, and acute lymphoblastic leukemia. And then our chronic leukemias, which we won't talk about today, but are chronic myeloid leukemia and chronic lymphocytic leukemia. And in general, when I think about the big differences between acute and chronic leukemias, our acute leukemias are the ones that where patients develop symptoms over days to weeks. They're often presenting kind of urgently to the emergency room. They're having significant symptoms of fatigue, and they have significant lab abnormalities. And these are the leukemias that are life-threatening if not treated urgently. Whereas conversely, the chronic leukemias are leukemias which they have good treatments for, but patients often die with instead of die from these leukemias. So they're very different presentations, very different treatments. And today, as mentioned, we're going to focus on AML and specifically on Venetoclax. And then to give you a little bit more of just some background information, I like to highlight this because if you can understand where the disease is coming from, you then understand what symptoms you're having, but also more importantly, what side effects you tend to have from the chemotherapy options or any treatments that you're getting. So this is you have the hematopoietic stem cell, which the analogy is like a embryo that grows into a fetus. So, cells as they mature, they differentiate and become different types of normal cells. So the lymphoid cells are in charge of a certain part of our immune system with our B and our T cells. And then the myeloid cells are normally, if you know, in the majority of patients, when they develop, they become our neutrophils, our red blood cells, and our platelets, as well as some of our other immune functions. But unfortunately, when these cells don't develop normally and get arrested and then develop into the myeloid cells, this is why the symptoms often our patients are neutropenic, or they have a low neutrophil count or immune system, or their hemoglobin or their blood level is low, or their platelet count is low, and they have symptoms of fatigue and bleeding because you have these cells that are supposed to develop normally that don't, and therefore the manifest these symptoms as a result. So AML is commonly diagnosed between the age of 65 and 74 with a median age of 68. Now, that being said, there is a wide spectrum, and both Dr. Mannis and I have created a cross-site spectrum, as well as, all our leukemia colleagues. And also, I think the important point here is that now we know, more importantly, that age is just a number, and that we don't, there's chronologically young, but then there's also physiologically young versus older, and how we think about that, and that's important in terms of treatment tolerability. These old definitions of quote unquote old and young are historic, based on our historic chemotherapy, because we didn't have very many treatment options at this time. But I think it's really important now to focus on physiologic age and focusing on the whole person and what the treatment tolerability and potential treatment toxicity are is based on that whole person. Okay, so now why is AML so difficult to treat? It's because AML is not, while it's one category and one disease in theory, there are so many different subtypes of AML. And this slide is showing the different combinations of different molecular mutations that occur within a specific disease. So, for example, a patient might have mutations like NPM1 or FLT3. I think of it as, here, think of the circle on the right as around the border are there different types of mutations that a patient can have. So think of this as a different color-coded flag that sits on the surface of the cell. And so then what happens is the adjoining, bars across the circles are the combinations of color-coded flags that the cell will then present. So for example, on the top right, you can have a DNMT3A, and on the kind of bottom leftish, you have NPM1. And so, a patient can have just one of those, or they can have a combination of both of those flags, or sometimes it's 2 or 3 flags. And so every patient is different. So it's important, I bring this up because it's important to know what your different color-coded flags are, and ask your oncologist what mutations you have, because we know a lot more about AML than we have in the past. And we have a lot of new drugs that are being, that can target, some are target specific mutations and some we haven't developed yet, but we're learning more about the likelihood of response to treatment, and what the different treatments are based on what your mutations are. So it's very important to understand that. The other thing that makes treatment really challenging is, it's not, say you have your 4 color-coded flags at diagnosis represented on the left. Unfortunately, in those patients who relapse, you can then have a different color combination. It would be easy, and it would be nice if it would be, oh, if you have the red blue combination, that when you relapse, you get those red and blue flags come back. And that can happen some of the time, but sometimes you get an orange and purple colored flags, or sometimes you're getting, black colored flags. And so there's just, so it's very important to understand what your flags are, or the mutations you have are at diagnosis. But equally important is that if your disease relapses, is to also know if those color-coded flags, aka mutations, have changed. So historically, I put this cartoon up because we historically for 40 years we used one type of chemotherapy. It was induction chemotherapy called 7 and 3, and we gave it to everybody kind of irrespective of age, irrespective of, of mutation status. And so it was because it was all we had, and so this is what we did. But the great news is that we've accomplished a lot, especially since 2017. We've had 11 FDA approvals, so it's really been an explosion since 2017. But just looking historically, our 7 and 3 was developed in the late 1960s, 1970s, and that really remained our kind of gold standard. And it wasn't for lack of trying. It's just that AML is incredibly stubborn and tricky to get rid of. And so other attempts were made at other drugs. They just hadn't come to fruition. So then the only thing that, occurred more recently before 2017, we had the backbone of our hypomethylating agents, azacitidine and decitabine, which will come into play very shortly with venetoclax, and gemtuzumab, which was approved and then pulled off the market and then reapproved. And so it was been challenging until recently, where now, we have kind of a wealth of options, which is a good thing. Okay, so listed differently, and here too, just for your reference too, is just the list of the drugs that have been approved and when the month and the year that they were approved. And so these are broken down into categories of newly diagnosed, relapsed and refractory, the combination, and then also something called maintenance for patients who have been done with intensive chemotherapy but aren't able to go to transplant. Some of these are targeted specifically to a specific mutation, and some of them are mutation agnostic. So now let's focus on venetoclax, which was FDA approved in the United States in November of 2018. And so based on the indication, it is approved for newly diagnosed patients with AML this is based on the clinical trial, but more than 75 years or older, or with significant comorbidities that preclude them from receiving intensive chemotherapy. And this is approved in one of two ways, either in combination with a hypomethylating agent, and those are either azacitidine or decitabine. And then the second option is venetoclax with a different chemotherapy called low-dose cytarabine. Most commonly in the US, we use the venetoclax plus the hypomethylating agent. So now let's get into how does venetoclax work. So in terms of the mechanism of action, it is specifically called a BCL2 inhibitor. And so what happens is when BCL2 is activated, you end up getting, for lack of better terms, the AML cells are then able to grow and thrive. However, if you have venetoclax, it inhibits this BCL2, and then you're inhibiting the ability for this AML cell to grow and thrive. And so therefore you're getting apoptosis or cell death, where the cells are now dying. Venetoclax is unique in that it is mutation agnostic, meaning that it doesn't really matter what color-coded flags you have. Now, venetoclax works better for certain mutations than others, but you don't have to have a certain mutation to receive venetoclax and be approved for venetoclax in the newly diagnosed setting. So when we look at response rates, so from our standpoint, we're looking at something called a complete response or a complete remission. And what we're looking for is that we want to see patients who go down from their baseline number of blasts, which are over 20%, to less than 5% blasts. So that's the goal of complete remission. And that is, and then that varies a little bit depending on what your other blood counts are, but for simplicity, we'll just say less than 5% blast. And here you can see, if we're in what's highlighted here, is that you see in all patients who were treated with venetoclax plus the hypomethylating agent, their response rate was close to 70%. Now, some people think that's high and some people think that's low, but if we compare it to our historical standards, this is significantly better than what we had previously and with a less toxic regimen. you can see that when we break it up by age, whether patients are less than or over 75, the response rates are similar. And then by mutations, this is where I'm saying based on the mutations, or again, I'm calling them color-coded flags, you can see that certain mutations have higher response rates compared to others. P53, for example, which we know is very challenging to treat, has a lower response rate to say our ADH mutations or our NPM1 mutated patients. And so the clinical trial that led to the approval of this combination of azacitidine venetoclax, it was a randomized phase 3. It was a trial called VIALE-A. And in this study, the patients were randomized 1-to-1. So at the time, the standard, if you were not receiving intensive chemotherapy, was just azacitidine. And so in oncology, typically our clinical trials are compared against the standard of care. And so usually nobody's just receiving a placebo. And so in this case, it was azacitidine as the backbone, and then they were randomized to azacitidine plus venetoclax. And either way, you didn't know whether or not you're receiving venetoclax or placebo. And here you see on the overall survival curve that you see that azacitidine plus venetoclax in blue is much higher than the azacitidine alone. This means that the patients with azacitidine and venetoclax had a significantly longer survival, meaning they live longer compared to if they only received the azacitidine alone. So venetoclax improves your overall survival, meaning you live longer if you take 2 drugs versus 1. And then on the right here, when we look at the trials, we break it down into all sorts of different variables. We look at gender and age based on geographic region, because this was an international study, looking at your performance status, the type of AML, your molecular mutations, and your bone marrow blast count. What I'm highlighting here is in red, which again is focusing on those color-coded flags and showing that depending on your color-coded flag, everybody still did better to the left, meaning it favored the combination of venetoclax plus azacitidine compared to just taking azacitidine alone. But you can see that the IDH1 and 2 mutated patients did extremely well. They're very sensitive to venetoclax compared to, say, our FLT3, NPM1, or P53. Now, they're still more sensitive, just not as sensitive as the IDH mutated patients. And so when the study was first done, when it was first published, the median follow-up was 20 months, so a little bit less than 2 years. And so there was a difference. And more recently, they presented longer term follow-up data, meaning that now they had been following these patients who are on study for 43 months. So, almost double. And what you still see is that blue line, the combination of the azacitidine plus venetoclax, is still higher than the azacitidine alone, meaning that even long term, the addition of venetoclax to azacitidine means that patients are living longer with this combination. And the overall survival for the combination is 15 months compared to about 10 months with just the azacitidine alone. Okay. So now the question is always, I don't know if other questions will come up when we talk about the chat, and, we're open to it in the Q&A. There's a lot of discussion about, we have azacitidine and venetoclax as a doublet, is adding another drug to have 3 drugs better? And I think that we don't know for sure in terms of the addition. It can make the regimen more effective, but it can also make the regimen more toxic. And it also depends on your mutation status and if you have an additional drug that you would be able to. Currently, there are different clinical trials that are looking at the addition of adding another agent to the standard of azacitidine plus venetoclax. And it seems promising, but we still need, confirmatory data to show definitively how exactly to give these regimens to maximize the likelihood of response while trying to minimize toxicity. So here in my take-home message here this is the analogy that I give to a lot of patients when they're coming to clinic, which is that a normal bone marrow is like a flower garden. And the flower garden consists of 3 different types of flowers. I call them daisies, roses, and tulips. And that represents your white blood cells, your red blood cells, and your platelets. And when you have AML, unfortunately, your flower garden is, infested with weeds that prevent your flowers from growing. And the goal of chemotherapy is to remove your weeds to allow the flowers to grow. And more specifically, kind of what a lot of what we've talked about is knowing specifically the types of flowers in the garden, meaning what molecular mutations are present, what color-coded flags, as I've been talking about, are driving the disease. And then also to understand the optimal conditions for growth, specifically in looking about modifying our standard approach to therapy and how we're looking at AML and looking at the whole picture and, looking at transfusion independence and also, different prophylactic medications. So a whole bunch of different factors. And then using the appropriate weed killer, so specifically our different types of treatments, we again want to look at the specific mutations that patients have to make sure that we're optimizing our treatment to what the patient is sitting in front of us, to both their specific mutation profile, but also their physiologic function and what they're able to what they're able to tolerate, and then also what their goals are, so that we can all work together to meet those same goals. And so with that, I will stop sharing and I will let Dr. Mannis take over and talk about dosing of venetoclax.
All right. Thank you, Dr. Lai. Let me pull up my slides here. I will start out. I want to thank Mary and HealthTree in general. I think I've been involved with HealthTree ever since the launch of the AML site, and I think they're doing really great things for patients and for those who are online or viewing this later. If you haven't already checked out the HealthTree site, a lot of great resources. I know a lot of my own patients have really raved about the information that they've gotten there. So again, I'm Gabe Mannis. Happy Veterans Day to those of you who are watching this live. I was actually on the phone with my parents last night, and they asked me if I had the day off for Veterans Day, and I told them I had to get up early to come into the office and give this talk, and they asked that I share the link with them. I don't think they're on, but if they are watching this later, hi mom, hi dad. Anyway, so I was tasked with the topic, how is venetoclax dosed? And one could surmise that that would be a relatively short talk. You could just look at the label on your pill bottle and that's it. But I think when we delve down into our understanding of venetoclax and the way it works that Dr. Lai outlined, I think the real answer is that we don't really know the best way to dose venetoclax. And I'll take you through some of the reasons why. But I think this is an area that is in evolution. So Dr. Lai shared this slide already. This was from the VIALE-A trial that led to the approval of venetoclax for newly diagnosed patients with AML who, for whatever reason, are deemed not eligible for more intensive chemotherapy approaches. And I show this slide again just to highlight the importance of this study in the history of AML. The majority of patients with AML are older. The median age at diagnosis is around 70. And so the majority of AML patients really can't tolerate super high dose chemotherapy. And so when venetoclax was approved back in 2018, what I tell patients is that previously the standard of care for older adults was azacitidine or a drug like azacitidine by itself. And with that drug, only 1 out of 3 patients achieved remission. It took 3 to 4 months to know if a patient was going to be in remission, and those remissions generally only lasted between 9 and 12 months. When you combine azacitidine with venetoclax, now 2 out of 3 patients will go into remission. It only takes about a month to get into remission, and those remissions last on average for 18 months. And so while those numbers, I would argue, still are not sufficient, we need to do better. We need to keep moving the needle. This was a huge advance in our ability to treat AML. I saw Dr. Lai had this slide or a slide like this in her deck and skipped over it, so I will just highlight this, that those numbers, those statistics where the median survival was around 15 months, we can actually break it down even further. And Dr. Lai referred to the specific flags that you may have on your AML cells, and that everyone has different flags. And when we use venetoclax in AML, we can actually look at just 3 or 4 flags and help better stratify how well patients will do. And so there is a lower benefit group, those patients with this TP53 mutation, that really is a huge unmet need. We really need to find better treatments for these patients. The survival with venetoclax-based therapy is still only around 6 months. There's an intermediate benefit group that has a mutation in FLT3 or one of the RAS genes, where the median overall survival is around a year. But the majority of patients don't have any of those mutations, and they fall into this higher benefit group where the median overall survival can be 2 years or more. And I have patients in my clinic, and I'm sure Dr. Lai does too, who have now been on this treatment for 4 or 5+ years, never been in the hospital, going about their lives, living a good quality life. And so that's what we are aspiring to get to for all patients. But really, this is an important drug to understand how to use properly, because if it's not used properly, I would argue that the outcomes are not so good. And so part of the job of people who specialize in AML, like Dr. Lai and myself, is to sort of educate both patients and their doctors to try and get the best possible outcomes out of their treatment. For those who aren't familiar with it, the National Comprehensive Cancer Network is sort of the body that oversees how AML is treated in the United States. It impacts insurance coverage, but also just every year meets to compile the evidence and make recommendations. I'm part of this panel, and I show this just to show you this is the page for patients who are not eligible for intensive induction chemotherapy. It divides patients into 3 groups: those with a FLT3 mutation, those with an IDH mutation, or those without any actionable mutations. And just to drill down on each of those categories, if you don't have a FLT3 or an IDH mutation, the preferred regimen is either azacitidine or its related cousin decitabine in combination with venetoclax. The same is true for those with FLT3 mutations, and in fact, the same is true for those with IDH mutations, with one exception, that there is an IDH inhibitor that is approved in combination with azacitidine. But I would say in the United States, it still probably is most common across the board, regardless of what flags you have on your AML cells, to receive either azacitidine or decitabine in combination with venetoclax. So the outline for my talk, just for the next few minutes, is sort of general tips for managing venetoclax plus one of the hypomethylating agents. And the broad categories are what to do when starting treatment, how to monitor when you're on treatment, and I think most importantly, management of low blood counts while on treatment, which is very, very common. Before I get into those details, just a few disclaimers. I would say, because I think we don't fully understand exactly the best way to dose venetoclax, every leukemia doctor has a slightly different strategy for for its dosing and management. The following is how I typically use Venetoclax, but I don't want people to freak out if this is not exactly the way you are receiving it or being recommended to take it. But the most important takeaway is that every patient and their AML is unique. Every patient on this treatment needs close monitoring to ensure that it is as effective as possible and as long-lasting as possible. I think a lot of oncologists are used to treating breast cancer or lung cancer, where you set a certain number of cycles, you kind of plug in the orders, and patients are on autopilot. They may not see their doctors for another 3-6 months to see how the treatment has gone. And this treatment really isn't like that. This is a dynamic process where adjustments need to be made along the way. And so if that is not happening for you, then you should reach out to your treating provider. So before starting treatment, I like to cook, and so I'm a big fan of the mise en place technique, where you prepare all of your ingredients. And so this slide is about preparing the ingredients. Most people who are newly diagnosed with AML will need frequent lab work, will need frequent transfusion support, will need infusions of either azacitidine or decitabine. And so typically I recommend that patients, rather than just a peripheral IV that they insert into a vein each time that blood needs to be drawn or something needs to be infused, that you think about placement of something that can stay in, either permanently or semi-permanently, and these include a PICC line. PICC stands for peripherally inserted central catheter. It goes into the upper arm and can stay there for several weeks or months. The alternative is a port, which is placed, it's a minor surgical procedure where something is placed underneath the skin. The main difference being that a port doesn't have to be covered when showering. It doesn't have any dressing that needs to be changed. We often will place a PICC initially because it's a little bit safer when the blood counts are low, but then transition to a port once the patient is in remission. One of the key things that I see happening incorrectly in the community is the use of prophylaxis, preventative medications against infection. So one of the biggest risks for patients with leukemia, especially when starting treatment, is the risk of infection. And so we typically recommend for covering all three of the potential types of infections: bacterial infections, fungal infections, and viral infections. And so as long as patients have low blood counts, we will typically use a daily antibacterial. We typically use levofloxacin, but some patients do have allergies to this type of medication or other reasons why they can't get them. And so there are alternatives. The antifungal piece is important. Fungal infections are very difficult to treat, can be life-threatening. And so we typically will use an antifungal such as posaconazole. There are other alternatives, isavuconazole or voriconazole. Importantly, I see a lot of patients started on fluconazole. One of the issues is that the newer antifungals like posaconazole can be very expensive. Sometimes insurance doesn't cover them, and so sometimes patients receive fluconazole instead. And I think an important issue with that is that fluconazole does not cover some of the most dangerous types of fungal infections. And so depending on the geography in which you live in, those types of fungal infections may be more common. Here in California, where I practice, it's very common for patients to develop these types of serious infections. And so we always try to have our patients on one of the newer generation antifungals. Lastly, antivirals like acyclovir. These mostly prevent against the development of things like shingles, which is a viral infection, or other herpes infections. And so preventing against infection is a key part of preparing to start treatment. Finally, there is a relatively rare potential complication of starting treatment called tumor lysis syndrome. Essentially what this is when you start to treat the leukemia cells can break open and spill their contents into the bloodstream. Those contents can affect the heart, they can affect the kidneys, and so it's very important to be well hydrated to help flush these contents through the kidneys, as well as this medication allopurinol, which is typically used for gout, and some people may be on it to treat gout. The same chemical that causes gout can be released from the cells when they die and can affect the kidneys. And so typically we will have patients on allopurinol and encourage them to drink lots and lots of water. So again, strategies to help prevent this tumor lysis syndrome. One strategy is just to ensure that the white blood cell count is below a certain level, typically around 25, so that there are fewer cells in the blood that can break open. And there are various ways that we can reduce the white blood cells prior to starting treatment. The dose of venetoclax does not typically start out at the target dose. For the first 3 or 4 days, there is a slow ramp up to try and mitigate the possibility of tumor lysis syndrome. And so typically it's 100 milligrams or 1 pill on day 1, 200 milligrams or 2 pills on day 2, and 400 milligrams or 4 pills on day 3 and thereafter. That is unless one big caveat, and that is if you are on other medications that may increase the venetoclax levels in your system. And this is a really big issue, and it's an unfortunate one because venetoclax does interact with many other drugs. And they're not just weird, rare drugs, they're very common drugs. And in fact, 2 of the antifungal medications that I just mentioned that we typically will have patients on, voriconazole and posaconazole, these drugs can increase the concentration of venetoclax in your system up to 4-fold. And so typically the recommendation is that the dose is reduced by 75% to a target dose of 100 milligrams. But there are other drugs that are also very common, like diltiazem or cardizem, which people may be on for cardiology reasons. Amiodarone, similarly, some people are on for atrial fibrillation. Carvedilol or Coreg is another really common drug that patients may be on. All of these require specific dose reductions. And it is a common misconception that if you are reducing the level of the venetoclax, that, is it going to be effective? But keep in mind that these drugs will boost the level of venetoclax in the system. And so the dose adjustments are being made to ensure that every patient is getting approximately the equivalent of 400 milligrams of venetoclax per day. So some general tips for taking venetoclax for those who haven't started taking it yet. Generally, we recommend that it's taken with a meal. You should take it at approximately the same time each day. Drink plenty of water. I get a lot of questions. How much water is enough water? Generally, we say 6 to 8 8-ounce glasses of water per day. And if you haven't started taking venetoclax yet, and you're someone who doesn't normally drink a lot of water, we recommend starting this about 2 or 3 days before starting venetoclax. Another common question is, what foods should I or should I not eat? As far as interaction with venetoclax, there's really just one main thing that people need to be aware of, and that is grapefruits and grapefruit juice interact with the enzyme that metabolizes venetoclax, and so you have to avoid things that contain grapefruit. Less common are Seville oranges and star fruit, but if you're into exotic produce, please avoid those as well. Lastly, it's really important when you're starting treatment to report any side effects to your treating provider. Venetoclax really has very few side effects, but some of the key ones are nausea, fatigue, diarrhea, and constipation. All of these things can be managed, and so it's just important not to minimize these and to make sure that you bring them up with your provider. The last side effect that is more serious, but still very common, is fevers. And so especially in the first or second cycle before people get into remission. The chance of developing a fever is somewhere between the range of 30 and 50%. So a good number of patients will have fevers. This can be a medical emergency, and so this is something that needs to be reported right away, even if it's in the middle of the night, on the weekend. Be sure to call someone to let them know that you're having a fever. Monitoring while on treatment. So at the beginning, before people achieve remission, most patients will need labs drawn twice a week. Some patients can get away with once a week. Some patients may need 3 times a week, but I would say on average, most of the time I have my patients check their labs twice a week. This is because at the beginning, either due to the AML or due to the treatment itself, patients will need blood and or platelets. And so even if they haven't needed transfusions before starting treatment, because of the effect of the venetoclax and the hypomethylating agent on the blood counts, these may drop to the point where transfusions are needed. And this is really important to be able to administer this treatment safely. And if you're in a place where it's not easy to get transfusion support, it might be worth thinking about trying to find a place that does have easier access to transfusion support to receive your treatment. The most common finding will be that the white blood cells, and in particular the neutrophils, which is a subset of the white blood cells, will be low. White blood cells, perhaps their most important role is fighting infections. And so when the white blood cells are low, patients will be at an increased risk of infection. And so this is just important to be aware of, not to panic about. One of the mistakes I see being made out in the community is that when the blood counts are low, the doctors stop treatment. And it's important to recognize that the white blood count most often is low due to the leukemia, and it will not get better unless the leukemia gets treated. And so although most oncologists are not used to administering chemotherapy when a patient's white blood cell count is low, in this setting, it's really important to continue the treatment despite the low white blood cell count in order to ultimately restore proper immune function. How do we know if it worked? Usually, if this is going to work, it works within the first 4 to 6 weeks or so. Because it works so quickly, unless we are still seeing leukemia cells in the blood, almost all patients should have a repeat bone marrow biopsy done before the start of the second cycle. This is another common mistake I see out in the community where people aren't really used to using venetoclax and they don't expect a treatment to work so quickly. And so they don't plan another bone marrow biopsy until after 2, 3, 4 cycles. But it's really important to do an early reassessment because it will help inform the timing of the next cycle, the dosing of the next cycle, and can be used to further stratify how well we think patients will do with this treatment. So what do I mean by this biopsy informing treatment? So Dr. Lai alluded to this. What does it mean, complete remission? So complete remission is not the same as cure. Cure means that there's no leukemia left in the body and the leukemia never comes back. Complete remission means that we can't detect the leukemia and that the blood counts have returned to normal. So as Dr. Lai mentioned, bone marrow blast percentage less than 5%, with a normal neutrophil count or a mostly normal neutrophil count and a mostly normal platelet count. So this is just sort of a handy table to sort of help interpret what to do based on the end of cycle 1 bone marrow biopsy. So the most common scenario will be this top row where if the blast percentage is less than 5% and the neutrophils are low, the really important thing is to delay the second cycle to allow the bone marrow to recover. So Dr. Lai mentioned this flower garden. If you get rid of all the weeds and it's just soil, there's nothing there. If you keep hammering it with chemotherapy, nothing's going to grow. So if you've gotten rid of all the weeds, you got to pause, hold the chemotherapy, let the flowers grow back in the garden. If there are less than 5% blasts, but the neutrophils are normal, that's great. It's not that common, but if the blood counts are normal and there's no detectable leukemia, just go ahead with the second cycle. You may or may not need to change the number of days that you received in the first cycle. But then scenario 3 is that if you still see a good amount of leukemia, regardless of what the blood counts are, you need to go ahead with cycle 2 and hope that cycle 2 will ultimately get the leukemia into remission. So 3 different scenarios to sort of help interpret the results of the first post-treatment biopsy. So life in remission. Once you're in remission, this is a really important point. Unfortunately, we don't think of this treatment as a curative treatment. So there are some cancers, breast cancer, lymphoma, where you may say, we're going to do 6 cycles, and if it works, we'll stop. And then you may not be on any therapy, you may be on a maintenance therapy. This kind of treatment only works as long as you keep doing it. And so there is really no set number of cycles. As we talked about at the beginning, although this has greatly improved outcomes for patients with AML, we still have a long ways to go. And most patients are only on treatment for a year or 2 before it stops working. And so it's really important to continue on treatment as long as it's working. One of the biggest challenges to staying on treatment is that low blood counts when in remission are very common. So at this point, the low blood counts are not from the leukemia itself, but from the treatment. And so we know that low blood counts tend to be more common and more significant in patients who are much older, patients who start treatment with a relatively empty bone marrow or with scar tissue or fibrosis in the bone marrow, patients whose AML has developed out of a pre-existing bone marrow problem like MDS or CMML, tend to have lower blood counts with treatment. And those patients whose AML has developed because of a pre-existing cancer that they received chemotherapy, which unfortunately we see, those patients also tend to be more sensitive in terms of their blood counts. When this happens, we decrease the duration of Venetoclax, not the dose. So don't cut down from 400 milligrams to 200 milligrams. We generally will cut back from, say, 3 weeks down to 2 weeks or 2 weeks down to 1 week. We also would consider using booster shots to help boost the white blood cell levels. Those go by names like GCSF, Neupogen, Zarzio. And importantly, making these adjustments does not appear to impact how long patients stay on treatment. And in fact, if you don't make these adjustments, the sense is that patients stay on treatment less long because they get infectious complications or other problems that prevent them from staying on treatment. So I will wrap up here with my takeaways, the do's and don'ts to help patients stay on treatment longer. Apologies for the keep patients on treatment longer. So do remember to start appropriate prophylaxis against infection and tumor lysis syndrome. Remember to adjust the Venetoclax appropriately for other medications you may be on. It's important to repeat a bone marrow biopsy early on in treatment to help make sure that you are getting the proper dose and schedule of treatment. And lastly, continue treatment as long as it is continuing to work. And then my don'ts, don't be afraid to adjust the duration of Venetoclax once you get into remission to avoid infectious complications. And don't be afraid to use growth factors to help support the white blood cell count. With that, thank you very much for your attention. I share my email here. If anybody wants to reach out directly, I will stop sharing my screen. And yeah, I look forward to the Q&A.
Perfect. Thank you both so much for your presentations. They're incredibly insightful, and the way you both explained everything, I think, answered a lot of questions. So thank you both for your amazing presentations. It is time for the Q&A portion of today's webinar. So if you have questions about anything that our presenters talked about today, this is your chance to ask questions. We specifically set aside this time for our community members to be able to have a chance to talk to our presenters, so please feel free to send in any of your questions into the Q&A. As a reminder, you can ask your questions or make a comment by typing them in the Q&A. So we have our first question came in, and the question is, why is there not a set dosing plan for AML? How much can this vary from physician to physician? So we'll put that to both of our panelists.
Dr. Mannis, you wanna take a stab at it?
Sure. I mean, I can tell you with almost 100% certainty that Dr. Lai and I probably use Venetoclax differently. And, it is unfortunate that there is not a set dosing plan. And I think to explain it, I would say that when the trials were designed, there was a way that the study was planned. And so everybody did it that way. And as we've gained experience over the years, I think we have learned a lot more. Unfortunately, as Dr. Lai showed, everybody's AML is different and every person is different. And so, unfortunately, there's as much art to managing Venetoclax as there is science at this point. And so, I think, ideally 10 years from now, when we've done more trials, gained more experience, maybe, for each subtype of AML or for each patient, we may have, here's the plan. But at this point, I think it's still a work in progress and we're still figuring this stuff out.
Yeah, I'll echo that, and that I think that we try to kind of piggyback on what you said, is that we tried to do a set dosing in the early studies, and even when it was first FDA approved, and we realized with time and experience, as you mentioned, that it's everybody's response is different, and the strategy is different, and now we know more about even more about the mutation profile now than we even did when it first came out. So I think it's just constantly evolving. I think kind of I really like your last slide, your takeaway slide, Dr. Mannis, because I think where leukemia doctors do have a cohesive message is in bone marrow biopsies after cycle 1, prophylactic medications, adjusting the medications adjusting the duration and not the dose of the Venetoclax based on an individual response. So there's common themes and messages, but then it's tailoring that the regimen to the individual patient.
We have another question that's a follow-up on, so does it matter what time of day you take Venetoclax? Does taking it at night help with tiredness?
The more important thing is taking it about the same time every day. Now, does it have to be exact? I think there's some wiggle room there, because it's more important to, if you forget and it's an hour later, to take that dose than to miss the dose. And so, there is that flexibility around there. But I would say, some of that is also a little bit of trial and error in terms of the side effect, maybe not the fatigue, but I've had some patients who have some GI side effects, so maybe more nausea, or so around the time of the day, or based on when they're eating. So that might change a little bit. So it is a little bit different for each patient. Dr. Mannis, do you have anything to add?
No, I would agree. I don't think it really matters. I would say in my patient panel, it's about 50-50. Some prefer to take it in the morning, some prefer to take it at night. I'm terrible about taking medications, and so just having a time when I remember to take it is the most important. So I agree. Just making sure you take it every day around the same time is really the most important thing. And you can sort of experiment on your own. If you feel better taking it at night or in the morning, you can do a little trial and error.
Couple more questions. We have one. Any new drugs that target the NRAS or EZH2? I was diagnosed January of this year with AML, these mutations, and did the 7+3 regimen to start. After I did Ven-Zen combo for 1 month of maintenance, and then went to transplant. Post 8 months in remission, some GVHD, but they are doing okay.
That's great to hear. It sounds like you've been through a lot, but I'm glad you're doing well. So we know specifically that the RAS mutations there for patients who start on azacitidine venetoclax, that while the RAS mutated patients are in that middle group that Dr. Mannis showed in terms of response and duration, we know that there are more of those mutations that can develop or evolve over time. So that's one thing that we're looking into in terms of venetoclax resistance. For EZH2 inhibitors, I believe we don't treat lymphoma, but there are EZH2 inhibitors for lymphoma, but that doesn't mean that they work in leukemia patients and specifically in AML, so we haven't made that bridge yet.
Is it necessary to take venetoclax with food? Another specific question.
I don't know if it's necessary. It's definitely recommended. So, I would try, even if it doesn't have to be a big meal, but I think just for absorption and for making it easier on your stomach, I think it is recommended. Yeah.
We have a question about how it's administered. So someone said they did the Venzen combo as pills and shots. Is it better to do an IV instead of the shots? They were painful and stained the skin.
Yes, so what you're referring to is azacitidine can be given either IV or subcutaneously. If patients are receiving decitabine, that's only given IV. But for azacitidine, whether it's given IV or sub-Q, it works the same in efficacy. So there's no difference in terms of one responding better to it or not. It's just preference. So Dr. Mannis alluded to, a lot of the patients are heavily transfusion dependent prior, and, our patients are also getting PICC lines commonly before we're starting treatment. And so because they already have a PICC line, it's just easier to administer IV. But there are patients who aren't that transfusion dependent, and get sub-Q injections. It's weight-based dosing, height-based dosing. So, depending on your size, you might get more injections. You can rotate sites. It does cause bruising. Some people don't mind, tolerate them very well. It's a shorter wait time. But some people, as it sounds like you're experiencing, have significant bruising and it's pain. We don't tend to switch in between a cycle. So say you get a few days of sub-Q, you can't then switch to IV during that cycle, but say with your next cycle, say cycle 2, you could switch to one or the other depending on what you're doing. I would say with the IV shortage right now, I am hearing that more sub-Q is trying to be used just until to get us through this hump, because one of the factories, was affected with the hurricane, but hopefully that will be short in duration.
Thank you for all of those answers and for helping to clear up some of those common questions that patients have surrounding taking different medications and those uncertainties that come with trying something different. We are over time, so I want to just finish with someone's comment that I thought was really sweet. So they thanked for the presentation, and then they said, one of the things to mention is that a remission brought on from this therapy can lead to eligibility for bone marrow transplant. I was one of the lucky ones that this happened to, started on venetoclax in April 2019, and then had a transplant in August of 2019. I've been leukemia-free ever since. I feel so fortunate for this therapy. So just a little positive story to throw in there. And then we are taking note of additional questions that have come in, and we will work to get those answered after this due to time right now. So thank you guys for your amazing presentations and for answering the patients' questions and providing us the information about this medication option. Before we sign off today, I wanted to highlight how connecting your records in CareHub can help you to see clinical trials and treatment options that you may be qualified for. So after you create your CareHub account, you can electronically connect your medical records from your facility into your HealthTree profile. If you live outside the US, the connection isn't an automatic, but our team of patient navigators can help you to manually connect your records. Once those are in, you can see a comprehensive overview of your medical history, your diagnosis, genetics, lab results, treatments, clinical trials, all of your information in one spot, which can really help you to be able to manage your condition and see what options might be available for you. On the screen, I have the link to sign up for CureHub along with the email address of our patient navigators. So if you have any questions, you're interested in using it, you can reach out to them and they will help you. I will also include the link in our follow-up email, so you can look out for that there. A few upcoming events on November 14th from 11 to 12 p.m. Eastern. We have a presentation that it's exciting about our regional cure teams that are launching. These are regional groups that you can be involved in if you want to get more involved with HealthTree. This one is specifically for the Pacific, Mountain, and Southwest regions. So if you're in any of those areas and you're interested in how to get more involved with HealthTree, you should join that event. And then on December 3rd, we're hosting our bi-monthly blood cancer financial Q&A with our financial coach, Diana Valentine, and she's going to answer questions about treatment costs and support. So another great one to join if you have any questions for her. You can go to the link on the screen, and that's where you can sign up for those events. I wanted to take one final moment to thank our HealthTree for AML sponsors who make events like this possible, Servies, Estella's, and AbbVie. And then finally, I just wanted to say thank you all for helping us to build our AML community. I added my email to this slide, so please don't hesitate to reach out if you have any questions about HealthTree, any of our programs, or getting connected to resources. We're happy to help. I so appreciate all of you, and I hope you have a great rest of your day, and I hope to see you at another HealthTree webinar soon.
Bye. Thank you so much for having us.
Thank you.
Thank you all.